All right. Did everybody have good lunch? I personally love the tortellini salad. That was really yummy. Okay, my goal is to keep you awake now that you've eaten. That's my job. Okay. So this next topic, the two questions I probably get the most often is what chart audits do I need to do and when? And what is the next drill or exercise I have to do? Because the term for the testing exercises really changed drastically in the last couple of years. Appendix Z is the driving force behind emergency preparedness. And there is specific set standards. That's the interpretive guidance, if you will, for the law that's written in 491.12. Appendix Z is how the surveyor is supposed to measure you to determine if you're following the requirements or not. And that had a major overhaul in 2019 when emergent diseases was added to the conversation. And then in March of 2021, it read like an after action report for COVID-19 and what all had to be included, how the clinic had to address specific areas. And there was just this major process that was put into place. When emergency preparedness was first developed for the RHC back in 2017, first of all, it caused a major panic. And then there was some elements that had to be in place regarding training and exercises. You had to do 2 exercises per year, and one had to be a community-based and one had to be a tabletop drill. That was the understanding. And then actual events qualify for anything. There has been some clarification given regarding that, and that's what we're going to dive into in this presentation. But first, I want to go over what's next. So there are times where we have new managers coming into the position in an already certified facility, and we were talking about this a little bit at lunch about you kind of have to do this gauge of where am I? Where am I at in the rules? Where are we at with compliance? Can I find proof of that because the manager took it with them when they left the clinic? Where am I at and what is next? Just tell me what I have to do next, Tressa. I have too many things on my plate. So that's the goal, to give you questions to ask when you go back to your clinic, to know how to review your documents, and to know what is next so that you can stay in compliance. Now, I have the owl on here, first because I needed something with green in it, because I had already developed the slides on the emergency preparedness testing cycle, and I had a green frog. And I'm like, oh, it's so cute. I don't want to change it out. So I needed something green just to tie it all together, because that's how my brain works. But also, it looks like he's asking the question, right? He's kind of doing that little processing question that you have in your brain when things aren't quite making sense. And so that's why I chose the owl, but I do think he's pretty cute. So our goal for this session specifically is to gauge where we are with the overall compliance of the clinic, determine where the clinic is in their testing cycle for emergency preparedness, and then develop that corrective action plan. And this leads back to, okay, I realize that we missed the ball, that we dropped something, something's not quite in compliance. How do I come back into compliance and cover my bases when it's time for survey? We're going to cover all of that. So some questions I have for you is, what is the date of your last program evaluation? If you can't find your last program evaluation, you need to do one pretty quickly here. If your last program evaluation is beyond 2 years, you also need to do a program evaluation pretty quickly. And then this comes back to that policy review. When you look at your policy, if your policy still says annual and your report is every 2 years, that's another issue. So look at your policy, look at your report, and determine when your last known report was completed. If it's beyond 2 years, that needs to be done ASAP. Not having a report is considered a condition level deficiency. So making sure you go back, check where you are, and get it caught up if it's currently out of compliance. Have you updated your policy? Review your policies and make sure you use the term biennial, not biannual, because that means you're doing 2 a year, not 1 every 2 years. It's a big difference. And how do you catch up if you're behind? Because we had some clinics that there was a misunderstanding when all of these waivers were in place for COVID-19, that the program evaluation was one of the items that was waived under the waivers. It was never put to the side. program evaluation was never something that fell under the emergency waivers. And so you would need to have a report in place for every 2 years to show that you've maintained that compliance requirement. Cover multiple years of data if you're behind, and create that self-report that we mentioned earlier. This is when I noticed that we were beyond the 2-year time frame. This is when we started gathering the data that we needed to review for utilization of services. Here's when we have our meeting scheduled, or our report will be completed by this date, and then start that process, because it can take time to pull all of that information together. It can take time working with your vendor to make sure your reports are pulling accurately. There are things that you need to be working on throughout that 2-year span or 1-year span, whatever your process is, to make sure you're ready for that program evaluation meeting or report. Now, the reason I keep clarifying that is because for a very, very long time, it was under the understanding that a meeting was the requirement. It is actually not required to house a meeting. You do have to have the report where you have all of the data listed. You have the outcomes of all of those reviews of your policies and your chart audits, and you have the report signed off by at least your medical director and APP. The community member, non-staff member, those terms are synonymous. The only space that they have in the requirements is in relation to your policy review. And that's just one portion of the program eval. You can do that prior to your report. That's the only space where they have to participate. Some clinics bring in financial conversation to this review because you're looking at your overall clinic. Some clinics bring in staffing issues into this conversation. And do you really want someone outside of your facility knowing the in-depth workings of your clinic? But the requirement for the non-staff member is that they review your patient care policies and sign off on them. Now, I do think there's something magical, if you will, about bringing everybody into a room, about bringing everybody to the table and hearing each other's conversations, hearing each other's ideas, troubleshooting together, brainstorming together, because you only go so far as the people who are present in that meeting, right? So the more people and players you can bring into that conversation, the more opportunity you have to determine what is our goal, how do we get to that goal, and what ideas can we put into place to accomplish that. But again, report is what's required. Meeting is definitely recommended because, again, there's something about bringing people into the room, having a common goal and common purpose, and determining what the next steps are for your program. How do you prove compliance? So typically what we see is when the surveyor comes into the space, they look at your policies, they look at your evidence binder if you have that put together, or at least the components that they're wanting to see. And one of those elements would be your previous program evaluation report. Coming back to the question that was asked earlier, how much do I have to save? How many reports should I have available? Recommendation would be from last survey to this survey to show that you've kept that ongoing review process. When you moved from an annual process to a biannual process, if that's something that you did. And then moving on from there. What needs to be included in your report? And this comes down to 491.11. This has to include your utilization of services. And one of the things that we would definitely recommend is looking at your last report to see, did you list out the volume of services, meaning how many visits you had? And do you know how many unique patients or number of patients are encompassed in that number? And having that breakdown available. So number of visits versus number of patients. Because you could have 10,000 visits, but then that only encompasses 9,680 patients, right? How many patients do you walk into your facility in that time frame that you're reviewing? And being able to differentiate that really helps you drive and paint a picture of where your clinic is at. The other element is that administrative audit that we talked about earlier, and documenting proof that you included a closed record within that and that you're meeting the number you put in your policy. Policy review is part of that, not just the signature page and done, but are you actually reviewing your policies? Do you know what they say? Are they current? Do you match your processes? Are you holding your patients and your staff to that policy and being able to answer that question? Are we following policy? And then the changes that might be needed. And this is another place where you can disclose those self-realizations, if you will. What changes are needed to our overall program? Base your performance improvement projects on the findings that you've had from your self-audits. Determine what are the issues in our clinic and how can we improve in these areas, and use that to drive your performance improvement projects. They don't have to be complicated. And then who needs to participate? And this is something that we covered already. The requirement for the report itself, the signatures that you have to have in place, is at least the medical director and one APP. However, if you're tying in the policy review portion, the approval of policies into that report, then you do need to include the non-staff member in that signature as well. Somewhere you need to have proof of the non-staff member reviewing your patient care policies. So it really just depends on how you're formatting that report, on what signatures you need to have in place. Does it need to be a meeting? No, as long as all of the information in 491.11 is covered. Does not have to be a meeting. It is very strongly recommended. And then this project can be outsourced. That's actually right in Appendix G, that you don't have to do it yourself. You can outsource that project. Okay, so here's the frogs. I didn't want to get rid of the frogs. I thought they were too cute. And the reason that I chose the frogs is because in my mind, of course, I'm a teacher by trade. So I think of leapfrog, right? You have the bouncing of every 2 years of the testing cycle. So that's why the frogs came into play. That's why the owls there. You're seeing my train of thought. I hope you're not scared. Let's dive into this. There are 4 categories for emergency preparedness, and Julie listed out 491.12 earlier, the high categories. We're going to dive into those a little bit into detail, but I'm really focusing in on the training and testing program because that's really what is shifting and moving in your clinic on a year-to-year basis. However, I do want to make sure you have the required components in place as well. So we look at the risk assessment. We talked about this earlier about each separately certified facility has to have its own clearly defined designated risk assessment, and it needs to be reviewed at least every 2 years. Even if the risks don't change in that timeline, we do need to show proof that it's being reviewed, having documentation that it's been reviewed in that 2-year time frame. Policies, and there are specific policies listed directly in the regulation regarding evacuation, shelter in place, medications, storage of medical records, making sure the continuation of care is present. Those are listed directly in 491.12 of what policies you have to have in place. We also recommend adding in lockdown because that seems to be the way the culture climate is going, having that directly defined in your policy as well, but it's not specifically listed in the regs unless you have active shooter as a situational policy. And then if you are through the compliance team, they do require that medication handling, your power outage procedure, be also listed in your emergency preparedness plan. So that's a nuance to them. I think it's good practice anyway. And then through the communication plan, I look at this as both internal and external. So the internal communication plan needs to include the staff at the clinic, not just the high leadership persons, all persons, receptionists, your clinical support staff. If you have volunteers, they need to be listed and vetted, at least trained on your plan and a documentation showing that they understand the HIPAA laws and that they're going to adhere to those. If you don't utilize volunteers in your clinic, you have to at least address that in your policy because it's specifically listed in 491.12. But again, in the communication plan, internally, you list anyone who works at your facility, what their main contact is, how you would communicate with them in the event of an emergency. You also want to list out your vendors. How do you ask for resources and supplies if you're stuck in shelter? What is your communication process? Who's communicating up to the hospital level if you're part of an integrated plan? Making sure both sides of that coin is covered. Because most of the time when we look at hospital emergency preparedness plans, the language all reflects what's happening in the hospital, and the clinic is not appropriately reflected, meaning they would not be able to open the book and put it into action within the 4 walls of the certified facility. So that's the question you would need to answer. And then the training and testing program, the external communication plan should cover at least your local authorities, your police, your fire, EMS, those types of things, your federal contacts such as FEMA, public health officials. And then the thing that we find missing most often is tribal emergency services. They do need to be included in your external communication plan. And we've been given a mile radius kind of as a starting point. If you have tribal emergency services within 50 miles of your clinic, they need to be addressed in your plan. I would go back and look at your contact list and make sure it's addressed. If they're beyond that radius, I would make mention of it to show that you thought about it, that you determine that it's not applicable to your facility, and put a statement in there that tribal emergency services are beyond the radius of our facility or something along those lines. All right, so now we're going to dive into what causes some clinics to have a headache. And there are two different types of drills, or a couple different types of drills. One is a community-based drill. And this is where you have multiple players from the community coming together and putting together an exercise that everybody is a player in. The definition would be a full-size exercise that includes multiple people from outside of the clinic, hospital, emergency services, your local fire, your local police. These are your big events. Hospitals are already putting these together. So a lot of the times, if you're a clinic that's tied to a hospital setting, this is easier for you to participate in. Some of our clinics that are independent, it's really a struggle to find this kind of a service because you're the one that's having to coordinate it, or to find another competitor maybe that's putting that exercise together and asking if you can be a participant. So that can be a struggle to become part of that process. I do recommend reaching out to your local police, your local fire department, your local health department, and seeing what might be available. I know that the state of Michigan has coalitions that put exercises together, and I would look into that. See if you can be a participant in those exercises that are coming to your area. Then there's the facility-based drill. And this is, I get asked if a fire drill qualifies for that. The way I like to look at a facility-based drill is it relates back to your risks you've determined through your risk assessment, but it's education and action together. It's not just putting a paper in a bucket and evacuating everyone from your facility. It is education and action. So you review your evacuation plan, you review how to use a fire extinguisher, you review your policy, and you review your floor plans and do what your routes of egress are. And then you carry out the actual exercise and evacuate your facility in time. How long does it take us to do our processing? So it combines education and action. That's what I define as the facility-based drill. Then you have those lovely actual events that throw everyone into a tizzy. This is where your plan is actually put to the test, where you have a weather event or you have a volatile patient that enters your facility and it causes you to go into action. You're putting those policies, evacuation, closing of your facility, sheltering in place. You're having to take an action that you've defined in your emergency plan, and the actual event is testing that. What I would say doesn't qualify is if it's something that happens every month, like a power outage or an EMR failure. If you've reported on it once, you're kind of one and done on that, right? So I wouldn't think that we want to report on the same thing every single year because there's not really a lot of growth opportunity within that. The entire intention of the exercise and drill testing cycle is that you're testing your plan, you're gaining education and preparedness so that if the event does occur, you're able to address it better the next time. And then tabletop drill. This is a facilitated discussion. This is where you ask scenario-based questions and then get people's responses of how they would respond if this was an actual event. And it is basically a round table is another way I've heard of that, where you sit down and you go through an exercise. Here's the scenario. At 10 o'clock, this is what happens. What would you do? Who would you contact? What actions would you take? And then at 11 o'clock, here's an update of what's happening. What would you do? Who would you contact? What actions would you take? And there's constant updates and then an outcome. And you have a hot wash is what we like to call it, where you analyze the outcome of that exercise and you put that documentation into an after action report. So the difference between a facility-based drill and a tabletop drill is the facility-based drill is that education and action together. The tabletop drill is just the education. No action required. So now we're at the leapfrog because CMS was so kind to us and tried to call it a burden relief is what was the documentation in 2019 when the testing cycle was updated to one every other year, or one per year, but there's a 2-year testing cycle. It's called burden relief, but I think it adds confusion, right? Because it used to be you report on an actual event, you do a tabletop drill, you're good to go. Then everyone thought, well, if I just do a report on an actual event every year, I'm good. Well, interpretive guidance came out with some clarifications of what qualifies for exercises and what type of exercise has to be done each year. So we're going to look at this, and I have some examples because, again, I'm a visual learner and I'm hoping that this provides some clarification. These slides will be available to you as well. So the first year in the testing cycle is what we call a required exercise. And this is considered either a community-based drill or a facility-based drill. The second year in the testing cycle is called an exercise of choice. I like to call it a planned exercise. And this is either a community-based drill, a facility-based drill, or a tabletop drill. Do you see that the first two duplicate across both years? That'll come in handy in a minute. Now we have the fun of an exemption. This is probably what throws most clinics for a loop. When do I get to skip my exercise? If I have an actual event, they tell me I don't have to do an exercise. Unfortunately, the only time an actual event is considered an exemption is from your next required exercise, which is that first year in the testing cycle. Are you confused yet? There's a lot of moving pieces within this documentation. And we're going to come down for a landing at the end of what's considered compliant and what's considered non-compliant within the after action reporting process. So here is what we like to consider a tracking tool. Here's what we use with clinics to determine what they've already done. And I would challenge you to go back to your facility, look over your after action reports and put them into this and define them. Did it qualify as a required exercise or an exercise of choice? So that you can see where you are in your testing cycle. This is an example of what one clinic did in February of 19, before the world fell apart. They did a community-based drill on active shooter. They had all of the hospital and the EMS and the fire department and the police department come in, and they did a community-based drill. That's year one, required exercise. Then in 2 of 20, so February of 20, the month before everything fell apart, they did a facility-based drill on the topic of fire. So again, education and action. So they did the review of their policy, training on the fire extinguisher, and ran an actual evacuation drill. Then COVID hit, and they had an actual event. So they did their after action report in 8 of 20, but we knew we were still in the midst of all of that. So then their next exercise would have been year one in the testing cycle, required exercise. But because of that actual event that took place, they had an exemption. They didn't have to do an exercise in 2021. So then when they come back into their next exercise that they had to do, it would have been in 2022, and they were able to do a year 2 type exercise, which was a tabletop drill. Now, I don't like the table version, so I put it into a pretty little picture for you. And this is the leapfrog event. So if you look at the first leapfrog, they go from year 1 to year 1, but they're able to jump over that frog in the middle that has an X because they had the actual event. Then if you look at year 2, they go from 2 to 2 to 2. There's nothing that exempts you from having to do an exercise of choice every other year. You always have to do an exercise of choice at least every other year. Then this clinic was on a different testing cycle. They were at the facility-based drill in 2019 and community-based drill in 2020. So they had just done the big year 1 drill right before COVID hit. So then they did another planned exercise, and their exemption didn't come into play until January of 22, even though the actual event took place back in 2020. Because your actual event exempts you from your next required exercise. So again, here's that visual, same exercises, same drills that they did, just with the visual of every other year. So let's boil this down. What does this mean for me? How do I know where I'm at in my testing cycle? Here are the things that you should know from a compliance standpoint. Clinics that are looking to just become initially certified, so they're not yet certified into the RHC program, you have to have a reported actual event or a required exercise prior to certification, leading up to certification. The clinic may participate in a community-based drill or a facility-based drill every year and be considered in compliance. So if you want to simplify it, if you do a community-based drill or a facility-based drill every single year and just count your actual events as gravy, that's one way of simplifying how to stay in compliance. Exactly. One of the things that causes confusion is what is non-compliant. Conducting a tabletop drill every year as your only exercise is considered non-compliant. It's only allowable every other year for that exercise of choice. And only reporting on actual events is also considered non-compliant because it only qualifies as your next required exercise every other year. Now, one thing that they did clarify is they said, well, what about clinics that are participating in community-based drills on something that's happening down in Louisiana, up in Michigan? That doesn't make sense to me. We don't have hurricanes up here. So what they did is they added language to Appendix Z, because that's what they do. And they said, not only do you have to follow this testing cycle that seems super confusing, now whatever exercises you do have to relate back to your risk assessment. It has to make sense to your clinic. And it can't be repeated every year. So you need to diversify your exercises, and it needs to be related back to that risk assessment. So what happens if we're 5-6 years down the road, we only have top 5 risks? What do? We're kind of up a creek without a paddle. So the recommendation is to really use that review. Every 2 years, you're supposed to be doing a new risk assessment. Has the risk changed to your clinic? Is there something new that we could test on because we changed our risks? Maybe there's a new factory that came into town that could cause an explosion or something that you need to identify as a new risk. Maybe it's something that we didn't notice before, or it could be that you identified a risk such as power outage, but then in the meantime, since your last review, you've gotten a generator, so it's not as high of a risk anymore. So that review of that risk assessment becomes more and more important, because that's what's driving how you determine what your next exercise is going to be. And again, diversifying topics, so we're not doing the same thing every year. So how do I do a self-audit? How do I know if I'm where I'm supposed to be with testing exercises? Where's your clinic in the testing cycle? Go back and look at those visuals. Go back and look at your after action reports. One, make sure you have after action reports, because some clinics did all the work and they don't have the documentation to show it. So make sure your after action reports are up to date. Check and see what the date was, what type of exercise it was, and determine where you are in that testing cycle so that you know what's coming up next. And then diversify. Make sure that you're not doing the same topic every single year. Make sure it refers back to your risk assessment. And then when is the clinic's next drill due, and what type of exercise will it be? And that's where we come back to these tables. So we go through this process, year 2, year 1, year 2, year 1, year 2, year 1. So they know that they just completed in January that tabletop drill, and they have a report in place. So their next exercise is not due until January of 24, and it needs to be on a required exercise because that's where they're at in their testing cycle. Unless, of course, they have an actual event between now and then. I don't cross my fingers for that. That was not good. And then after action reports, I went to a clinic, and one of the questions that I get asked most is, how far back do I need to keep my reports? How long do I need to keep this report in my binder? Because my binder is getting out of control. And the way that the surveyor is instructed in Appendix Z is to look at the last 2 testing cycles. So that would mean 4 years of reports. So I would make sure when you go back to your clinic, you look at your emergency plan, you look at your after action reports, and you can show that you have at least 1 after action report per year for the last 4 years. Now, one of the things that I appreciated is in the height of COVID, you had enough to deal with, right? So one of the things that the accreditor was doing, compliance team specifically, is they said you can report on COVID-19 for 2020, And then 2021, you could report on your vaccine clinics. That was a shift that changed, and it was a planned exercise because you had to put all the effort into putting that into place. So that was a way of being able to use the same topic, but you're looking at it from a different lens. And that was something that they allowed so that you didn't have to create another event in the midst of dealing with an event. If the clinic has only reported on actual events, if you have 5 reports on power outages, you need to put together a planned exercise as quickly as possible. And then this is where we get that page number on Appendix Z of where we're told what the surveyor is actually going to measure you to. And that's where in Appendix Z on page 102, they're supposed to review the previous 2 testing cycles, which would be that 4-year time frame. So this I should probably have highlighted in red. Confirm the clinic has documentation to prove compliance at time of survey. All right, we're going to get moving into the developing a plan if you are out of compliance in some of these areas, but I do want to pause for questions on either the program evaluation or emergency preparedness, because these are big areas for the RHC. Okay, anything online? Let's move on. I think people are falling asleep from lunch. Do we need to do a stretch now? Okay. Moving into creating a plan. Now, this is outside of the plan of correction you would have to do for a surveyor. These are those internal self-reports. You've done your due diligence, you've looked over your clinic, you've done that analysis of your overall program, you've looked at your emergency plan, you've looked at all your policies, and you've identified the areas that are in non-compliance. How do we address that? So this is where you're going to use all of that work you've done, the program evaluation, the emergency plan review, the policy plan review, the physical plant mock audit, the chart audits. You're going to take all of that work that you've done and you're going to boil it down to what would have been a deficiency. If we would have received a survey today, if me walking around the clinic had been the same as an actual surveyor walking around the clinic, what would have our deficiencies been? Because we have to start there. And how can I improve? And use that to drive your performance improvement projects. Put together a quality initiative. How do we improve our clinic? Quality measures can be based on patient care. That's where we want to get to. That is good quality care. But we can also develop our performance improvement projects based on the performance we're seeing is lacking in our clinic as well. So use the audit results to drive performance improvement projects and meet with staff one-on-one to address any areas of concern. And then conduct ongoing staff meetings to measure compliance improvements. How are we doing? Don't just set yourself a goal, but put measurements in place to see if you're obtaining that goal. Identify areas of improvement and define the action step to correct the action or the issue. Create a plan of correction for areas that will take some time to correct. So if it's not something that you can pull together within a week from your audits, I would put together a formal plan of correction, again, self, not out to the surveyor unless they ask regarding that specific topic, where you say, here's the issue, here's who's responsible for monitoring it, here's our monitoring steps, and then how often are we going to monitor it, and what is the date of this being completed and improved? Because that's what you would do if it was a plan of action from the surveyor. You'd have that formal step that you'd have to follow. Those are the questions you would want to answer to drive measurable goals within your clinic setting. And then develop tools to measure that success. If we just make this pie in the sky goal, how do we know if we're going to reach it? So put together, here's our goal, and here's the action steps of how we're going to reach that. Here's what we're going to do daily. Here's what we're going to do weekly. Here's what we're going to do monthly. Here's what we're going to do quarterly. Depending on the type of deficiency that you found, will drive how you're going to monitor that and maintain it moving forward. Who's responsible? And then update your policy and protocols. Policies can be a great tool to use to bring streamlining processes into your clinic. If it's a struggle across all of your clinical support staff on how to properly intake a patient, Put that into a policy so that you have a training tool with them and they can sign off acknowledgement and put together your proficiency of how they need to work out those actions. And then train and implement and do. And the doing part is usually where we get caught up because we have a million other things we're trying to monitor as well. But these need to be really brought to the forefront of conversation. One of the greatest ways to know what patients would agree for improvement is patient satisfaction. I will say it's not a requirement of the RHC to do patient satisfaction unless you're through the compliance team. They do require that, but it's good practice. We want to know how the community views us. Are we meeting the goals and objectives of our patients regarding their care? So patient satisfaction can be another way to gauge not only what we're seeing within our clinic, but how others are viewing us too. Now, that was very quick. I do not have my time up here. What time is it?
It is 1:12.
What time were we supposed to end?
Well, adjusting the it'd be 1:30.
So we're about 15 minutes ahead.
Yeah.
All right, now I know we have questions because emergency preparedness is a beast. Any questions? What are some things that has anyone been through a survey where their emergency plan was reviewed that they're willing to share? Any surprises or hiccups that they had? Or is this kind of a keep everything close to the chest kind of environment? That's okay too. Yes.
So I just have a question. For advice. We're in a big health system and we have one big emergency plan.
Okay.
What is is there a recommendation on what pieces specifically need to be?
Clinic. Okay, so the question is they participate in an integrated health system plan for emergency preparedness. What pieces have to be held at the clinic level? Is that a correct interpretation of your question? So what I have typically seen in a successful integrated emergency plan is you have the overarching language regarding how you handle infection control, but it needs to go one more, or I'm not sorry. I am sorry. I meant incident command. Apparently lunch kicked in for me as well. Incident command, but it needs to go one step further from here's the hospital's incident command of how does the clinic communicate up to incident command. And so we want to look at it as two sides of a coin. You have all of the requirements that are listed for the RHC in 491.12. They still have to be present in an integrated plan. And the big question that I ask when I look at an integrated plan is, can the clinic, the RHC, open it and put it into action within the four walls of the clinic? You can answer that question as yes, that's step one. Then the next item that I would look at is you have the overarching integrated plan, but the clinic should still have the supporting documentation within that. Those would be your facility map. What are the demographics of where the clinic is located from a geographical standpoint? It would be your floor plan. What is the routes of egress for this specific location? Your organizational chart. What is the hierarchy of command, the delegations of authority, the lines of succession within the RHC setting? And then you also have that internal communication plan, listing out all of the staff at the RHC, having that printed and available at the clinic, and that's supporting the overarching integrated plan. And then we also would recommend having that external communication plan listing out local, regional, county, state, tribal, and federal contacts from the clinic side. Because most hospitals are located in a larger area, then the clinics are out in these little tiny towns, and we don't see their local fire department listed in their communication plan because it's from the hospital's point of view. So those would be the two questions, looking at the overarching emergency preparedness plan and asking, does this make sense in the four walls of the clinic? Can they put it into action? And then are all of the supporting elements that the RHC has to have in place present? Any other questions? Yes.
There is one more question on mine. Who is required to write the quote after action plan does it have to be the medical director or can it be another provider or office manager?
There is actually no clarification of who has to document the outcomes of your exercises. Now, I think we complicate what has to be captured in an after action report. We do this elaborate documentation that's 20 pages long. The summary is really just what happened, what were our strengths, what were our weaknesses, how did we address those weaknesses, and what was the overall outcome of the event. That's boiled down what has to be in the after action report. It's just an analysis of the outcome of that exercise. What happened and what would we do differently if this event took place again? But there's no definition of who has to fill out that form. I see managers do that quite often. We have emergency managers at the hospital that oversees the clinic's testing and training cycles, and that's appropriate as well. The main requirement I would give caution to, especially for those that participate in an integrated plan, is if you do have your emergency manager creating the after action reports on the exercises they put together, make sure your clinic is listed as a participant, because that can get you in trouble if you're not listed. So that goes from a documentation standpoint, is the clinic reflected in the plan, but also as an analysis standpoint, are they reflected as a participant in the ongoing exercises and drills? One clarification I do want to make, as I said, training, that's a different topic than testing. Testing is the exercises and drills saying, does our plan work? Education is our staff understand our plan and know their roles and responsibilities within it. And that has to be documented and completed at least every 2 years, but we strongly recommend every year doing education with your staff. It needs to be done when you first develop your plan. If you're new to the program, it needs to be done upon initial hire within 2 weeks. And then at least every other 2 years, again, recommend every year. And then if there's a major edit to your plan, it needs to be education with your staff regarding those changes that are taking place in your emergency plan. And I believe you had a question as well.
I actually probably have a couple. So,
I have a couple of questions, and I'm actually part of that integrated plan, part of the same health system. So my question is, when you ask the question back, it has to be operational within the 4 walls of the clinic. I know often those plans we still rely on the bigger hospital to support some of that work. Does that mean independently the hospital would operate, or is it okay that we're still using the hospital if, I don't know, let's say there's a very specific clinic event happening, we'd still get the hospital involved. Is that still sufficient?
Yes, I would consider that a surge.
Okay.
And surge is covered under emergency preparedness, where you act as a surge for the hospital as an overflow, but they also act as a surge for you if you need assistance. So that's a back and forth communication, and that's very much allowable within emergency preparedness.
And I think that after action, you answered the questions about just making sure the documentation reflects that the clinic was involved.
Yes.
Is documentation enough to say, Jane Smith attended and she's the practice manager of clinic ABC? Is that enough, or do we actually need to list, clinic ABC participated in the after action? Because I feel typically we list people,
The clinic itself needs to be listed as a participant, and then under the participant number, your specific person who went would be listed there, but the clinic itself has to be listed as a participant. And in Appendix Z, there's allowance where you don't have to send everyone from your clinic to an exercise, but you should diversify who goes and then document participation within the report itself. What I typically see is the system puts together the overarching after action report, and then typically what happens is the clinic has to do its own addendum from their perspective of what the outcome of that exercise was to show their participation. That's one way we've seen clinics be successful with it, and that is adding to the after action report from the hospital.
Thank you. My last question is regarding training, and I think you touched on that a little bit, that this is really testing operations of the plan, but then there's also that training component, making sure we're aware of, gosh, this is our emergency operations plan, this is what we need to do in the event of ABCD, whatever happens. Is there any recommendation though, because we know there's FEMA courses out there, incident command courses that we can take? Are there recommendations or requirements that we should be taking any of those?
The only requirement for the RHC is what's listed in 491.12D. And that's where they define the training and exercise requirements, but it goes over both the training and the testing. So that's where you're held to that biennial training of your staff. And it comes back to what's my role and responsibility in this plan. We typically, when we lead a clinic through through education of their plan with their staff, we look at what are the risks determined for this facility, what are our meeting points for evacuation and shelter, what are the roles and the lines of succession, who's responsible for each of these actions that we're carrying out within our policies. And it goes through that in-depth review of the plan itself. What is my role? How do I communicate? How do I ask for help? And it goes through that full process. Most clinics add that into their onboarding training.
Any other questions with regarding to the emergency preparedness?
One quick note that I do want to make is the clinic is required to list out what secondary devices they have available at the facility. So most clinics use cell phones still, that's very allowable. Where I see clinics kind of trip up is if they're under the hospital's plan and the hospital says that they have walkie-talkies, ham radios, but it's not available in the clinic and you've not differentiated that within your plan, that can be something that gets you in trouble as well. Make sure if you have it listed as available at the clinic that it's there. Or make a section regarding your off-site facilities is usually the language that I see there.
Tressa, can you identify again your number one deficiency that you see?
In emergency preparedness, not having after action reports, that's really the biggest one. Not documenting what you're doing.
And is that for your practice or is that for real life? I mean, or is that for both?
It's really for across the board, all
Okay.
clinics. We have gotten to the point, at one point in a time, it was that the clinic didn't have a plan at all. We've gotten to the point where we've kind of moved away from that as a common deficiency. Most clinics have a plan. Now it is, does my plan have all of the components that are required? And so that's usually where we get to. One of the things that I do get asked often, especially by larger hospital systems, is do I really have to have a list of all staff? Do you realize I change that on a daily basis? Because we have so much turnover. And the response is yes, you do have to have a call tree, and it does need to reflect all staff that are in the clinic. We recommend putting that on a quarterly review basis so that it is kept current.
Awesome.
Thank you.
Thank you. And so we are going to do a 15-minute break and then we'll come back at